So SEMA4 and 4D, or SEMA4D is the target that Pepinemab binds to. It's present it's present in the neuroinflammatory microenvironment. It's upregulated on neurons in disease, and especially upon stress. So in both AD and HD, our target SEMA4D is upregulated. It could either be on the surface of neurons or it could be secreted, and it binds to its receptors, plexin B1 and plexin B2, that are on glial cells, notably astrocytes. And so the sort of short version of the mechanism of action is if we could block the interaction of SEMA4D to its receptors on astrocytes with an antibody, Pepinemab, we could reduce some of this stress that's passed on to the glial cells by the neurons. Our Huntington's disease trial was a phase 2 trial. It had, in total, it had about 300 patients in it, which was at the time a rather large trial for this orphan disease. Out of those patients, about 180 were in this early manifest HD population. So this is a population that's considered mild. They're showing symptoms, but they're not really advanced yet. We also had another population in this study, which I didn't present much data on, and those were considered prodromal HD. They're even earlier on in disease, and they really weren't showing much progression. That's one of the reasons we didn't talk much about that data, was because they weren't really progressing enough in order to be able to detect any treatment differences. So in this early manifest population, our main outcome was safety and tolerability, and it proved to be very well tolerated. We also looked at several clinical outcomes, such as cognitive function and clinical global impression of change. And then we also looked at several important biomarkers, and that's really what I stressed a lot in the CTAD presentation, which was metabolic imaging with FDG PET, some structural MRI, as well as some soluble biomarkers such as GFAP. The test in HD for cognition is the HD-CAB. It's a battery of 6 cognitive assessments, and they're put together in a composite index. And so what we showed was that in the placebo patients, as expected over the time from 0 to 18 months, their cognitive ability declined. Whereas in the Pepinemab treated patients, at first there was a slight improvement in cognitive ability, and then they also began to decline, but at a much slower rate than the placebo treated patients. So we were able to, this ended up being significant. And then we were able to also, when we looked at a subset of these patients, when you look at patients that were more cognitively impaired at baseline, their MoCA was less than 26, this difference got even bigger. And so it was, I think that helped show the validity of the test and the validity of the results, that the Pepinemab treatment was affecting cognition in a good way in these patients. Our main biomarker, especially because it fits with our MOA, was FDG PET. So FDG PET measures brain metabolic activity by measuring glucose uptake. And in both Huntington disease and Alzheimer's disease, it's known that a decline in FDG PET correlates with cognitive impairment. In other words, this hypometabolism in the brain is something that happens when patients get worse with the disease. And so we measured that in our HD trial. And in the placebo-treated patients, we looked at about 24 different regions of the brain, mostly cortical regions, and we also had a couple composites. And in the placebo-treated patients, we saw this hypometabolism, whereas in the Pepinemab-treated patients, in the majority of the regions, we actually saw a reversal of this hypometabolism. In other words, it prevented this loss of metabolism in many of these regions. And when looking at the difference, it was actually quite significant in many of the regions. So that was that was our main imaging biomarker. Another imaging biomarker we looked at was structural MRI. So it's also been known in both HD and AD that there's atrophy. The brain actually shrinks as these patients get more sick. And so we looked at a couple different ways to look at atrophy, both in the caudate, which is a region of the brain that's specific for HD that degrades, and ventricular expansion. And using both of these techniques, the Pepinemab treated patients showed a less of a reduction in brain atrophy. And then the last biomarker that we looked at, or at least that we had time to present at CTAD, was this GFAP. So this is a really well-known biomarker for astrocyte activation and dysfunction. So another reason why we were we were excited to look at this just because it fits with our MOA. And it's also shown that as patients progress in disease, their GFAP goes up, and this correlates with cognitive decline. And even in Alzheimer's disease, this correlates with the accumulation of more amyloid. So as the patient gets worse, this is a marker both in the CSF and very nicely in the plasma as well that can signify this astrocyte dysfunction. So we looked in the plasma over time from 0 to 18 months in our HD treated subjects. I mean, it was interesting because GFAP has not been studied as much in HD as it has in AD. So we had these samples we wanted to look. So we were happy to see that we saw this increase in the placebo-treated patients, and we saw a significant increase both at 12 months and 18 months with this Pepinemab treated subjects, suggesting that we're, this biomarker that we're reducing the astrocyte activation and dysfunction. I think we learned a bunch of different things. First of all, overall in a rather large study, we showed that Pepinemab was well tolerated. So we also another brief slide that I presented at CTAD was we did show that Pepinemab is able to cross the blood-brain barrier and bind to its target at the doses that we use. So we were able to, in HD, establish a dose and show that it was well tolerated. We showed that the mechanism of action that we ended up getting some data in HD for that. It's very relevant in AD. Astrocytes are also involved in neuroinflammation in AD. And the other interesting thing about our MOA is that, we've had some in the AD field, there's been some really exciting, new treatments approved that bind to A beta and try to get rid of that complex. So our MOA is alternative, and we hope, possibly complementary. So it may set up in the future for an ideal combination with two different MOAs. The other thing that's also very important to AD and HD is cognitive function, and so the fact that we saw that slowing and decline was important. And these biomarkers I talk about, FDG PET, MRI, and GFAP, even though we showed HD data, those are three widely used biomarkers for AD, and actually all of those are in the revised ATN criteria for AD as important imaging and soluble biomarkers.